Welcome to TCN Talks, an Anatomy of Leadership. We continue our conversation with Robin Heffernan in Part 2 of Carve-in or Carve-out, the future of hospice under Medicare Advantage. And now, here's Chris Comeaux. Let's go into the second segment, Robin, which is maybe a little bit of how we kind of found ourselves here. So the VBID really was a limited demonstration. Can you talk a little bit about what's your perception of what they learned? And does the data give you confidence that scaling this nationally will produce some of the good outcomes that you're predicting as opposed to maybe some unintended consequences?
Yeah. So I think the good things about VBID were the folks who participated saw, hey, if I do palliative care well and I get to a good hospice provider, that has a great impact on the patient and it saves me a lot of money. Like the happy path, everyone would agree, that was a really nice path. I would like to do more of that. The challenges for VBID, there was no teeth in terms of setting up a network. And so you could call it network leakage. You can call it patients just went to bad hospice providers. They had some bad experiences. They had some bad financial outcomes. The payer felt like, I have no way to control this. And so when you put those two things together, the economics were kind of a wash for the program overall. There were some good experiences. There were some bad experiences. But if you put the filter on it of, hey, if I fix the network problem and I was able to get more of the good, happy path, I think everyone would tell you, great, I would like to do more of this. The one other wrinkle that we heard about was you do have to solve this. Patient is getting curative care, and then the next day, they're supposed to not get curative care. And that's unrealistic. Why do we make patients go through that? And so how do we figure out a better path where it's not like hospice from day one is zero curative care, when some people may argue getting dialysis is not curative. It's a symptom management, right? I should be able to keep getting that. So I think we need to figure out what's allowed during hospice in a better fashion, which probably also aligns to I should figure out how to pay hospice more appropriately.
Boy, you and I could do 3 podcasts together. So again, I've kind of grown up. I was raised by nurses. I'm a CPA by trade. So I came from the business side and I would go out on visits with hospice nurses. And there's so many things now I look back on that they were teaching me these interesting pieces of wisdom. But the election statement, that, that human desire to live. My father-in-law is 91 years old. He's amazing. I pray he's with us 10 more years. And want him to be here as a family. And I'm a guy who grew up in hospice and palliative care. And so that election statement, it puts that creative tension on this is the pathway where you're going. And, some of those most beautiful hospice mission moments we talk about, people don't have tough conversations in their lives until they know that they're finite. And there's these beautiful outcomes that occur. And if you erase that line, and I'm not saying you're saying totally erase, it's almost like I'm hearing you say kind of create maybe a bridge of some sorts where you could have some concurrent care for a season, but that may be one of those unintended consequences that maybe we just have to be a little bit wiser of going, hey, there'll be this overlap space, but then there's still going to be this very clear space. I don't know if you want to respond to that.
100%, right? I mean, I think tactically, so VBID allowed a plan to test concurrent care bridges. And some of these plans did that and they saw this is a really great outcome, right? I can let folks have a certain number of days or a certain number of treatments or, there was a lot of experimentation that went on. And I just go back to, well, imagine there is no hospice fee for service. But I tell you, okay, you have this patient through expiration. You would design what care they're getting very differently, right? Than, they're allowed to get curative treatment until this day. Then they got to put that away. and do these other services. And so I think plans would inherently do some more experimentation, have these bridge paths, because they know that helps a patient effectively transition over this course of time. It meaningfully reduces their hospitalizations. They have much better experiences. Their patient satisfaction scores are way higher, right? And so even like the financially oriented metrics that the plans care about are better when we stop thinking about this as, okay, I like effectively have total cost of care responsibility for this patient until this day, and then it's a daily payment. And now I'm focused on how much am I paying you each day, and I'm not focused on the value that you're generating.
I love the words you use, the bridge path, because I do think sometimes we think about it very black and white that, well, then it's just all going to be concurrent care to the end. But maybe there is this like in-between stage between what we call palliative care today and what we call hospice today. There is this interesting, maybe potentially bridge path. Good. Well, let's go to another one. So a lot of independent hospices, especially the nonprofits, that's one I'm a little partial to. They operate on really thin margins. I think now it's negative 1.6% based upon MedPAC report. And I forget what the average for-profit, maybe theirs was 10%. And then the average is somewhere in between like 5%. And so how do we prioritize mission over scale? Maybe I shouldn't say it over scale, but does a carve-in accelerate consolidation? And are we comfortable with that potential trade-off?
I sort of look at services that have come up on this similar path. Primary care has come up on this similar path. Home health has come up. I think quality providers, regardless of their size, get rewarded. I also believe it is true that a lot of smaller quality providers, they don't have ambitions, right, to be in every county. And some large private equity firm comes along and offers them a really good deal. And then they take the deal because it's good for their family, or it's, it's sort of good for whatever is happening for them. And I think that will happen in hospice inevitably. But I think if you focus on total cost of care and you focus on these are the quality metrics that define good, then even if you get some consolidation, that big player still has to be good. Mm-hmm. Otherwise, they're not going to generate quality outcomes.
Which, we went into that a little bit in the measures that matter. You and Mindy were just so articulate that you may have a great provider today and then a leader changes over and then quality goes down. And you were lamenting, it's not like you found the perfect organization and they're great forever. There's a lot of waxing and waning, even where there's good stuff. And I don't feel like you totally said this, but I've done enough consulting in this world that some of the big chains, that's exactly the case. They may have brand Chris Comeaux Hospice, but one branch over another is not consistent amongst that brand. It's still a very service level field. And so where you and I kind of hit it off a little bit of like, because I grew up in manufacturing too, I think we're going to have an interesting potential renaissance. I don't want it to be all about the process, but man, when you marry credible mission with incredible process, systems that support it, you get great. And this to me is where our future is, which is where I get really excited because this is the type of stuff that we're working on as a network. And so I totally hear you that the trade-off's going to be there. Selfishly, I had such mixed emotions about doing this podcast with you because I really want to talk it through and you're doing a great job helping me see the other side. But I've been pretty against the carve-in, but yet selfishly for TCN, we're positioned incredibly because this is exactly why we created our network is to do this actual work. And our network is interesting because they could stay independent, but be part of something bigger. And you just affirmed, I just took a flyer and just because I grew up in the business world, I said, we used the quadruple aim and said, I don't know how this is going to play out. But if we focus on great service, great quality, great cost, and a great work environment for employees, it's got to work out good for us because people are going to be looking for that. And that's legitimately kind of how we created a clinically integrated network. We use the quadruple aim. Now we're using the quintuple aim as that rallying cry. And we still have a ton of work to do. But I feel like that's kind of what, I feel like you're very much affirming that, just because you're maybe an independent nonprofit somewhere or maybe an independent for-profit, if you're working on those things, there's a future for you.
Yeah.
And you're not doomed that you're going to have to consolidate with someone. Now, navigating it may be really sophisticated, which is, again, that's why we created our network to go. You may go, I'm not even sure how to talk to the payer. That's where we created our network. You have high-performing network as well, where you can help people kind of navigate that. But did you want to respond to any of that?
100%, right? If you're a provider doing great work, you will get rewarded. And I think probably those providers wake up every day and are like, if we could get the bad actors out of this industry, that's good for everyone, right? But we don't have a framework right now to really do that. Even I would say, it's nice that sort of the broader public is now recognizing hospice fraud, but they're still mostly trying to go collect on a bunch of wasted spend that they did historically, right? And there isn't a lot around how are we going to prevent this from continuing to happen? How are we going to assure and reward these smaller providers who are struggling with margin, right? So that they don't get subsumed by these larger bad actors. And I guess I'm more of the belief that unless you put the payers' feet to the fire and you make them financially responsible for bad outcomes, like burdensome transitions, this is a really slow uphill slog.
Gotcha. That's such a key point in what you just said. Let's talk pre-authorizations then. What are your thoughts on prior authorizations in post-acute care? Does medically necessary mean the same thing for acute and post-acute settings?
So medically necessary in terms of like home health or in terms of...
Yeah. And it really goes to the broader question about prior authorizations and just that concern of, again, every system is perfectly designed to produce the result it produces. If the payer just wants to reduce costs, are they going to make it really difficult via the authorization process, even to get people in the care?
Yeah. So I guess I would sort of reiterate, if a payer has done a deal where they have a guaranteed margin and it is your responsibility to take care of the patient, there'll be some medical necessity that they'll want done, just for good hygiene, but they're out. They're not going to try to limit the benefit. They're not going to try to push the benefit. They've gotten their guaranteed margin. And then it really becomes, well, now I need this patient to go to high quality hospice at the right point in time. Otherwise, I'll lose money.
Okay.
Right. And so I think putting focus on, do we have all the protections in the medical authorization, is the wrong focus point, right? Because if you put the focus on total cost of care, the payer says, I know how to do these deals. I keep some margin for myself. I mean, this is what they do with CMS, right? Like I keep 15% for myself. I then have 85% to spend on medical costs. They do these deals all day long. And then it becomes an MSO or a high quality network or the hospices themselves that say, okay, it's now my responsibility to take good care of this patient. And it is not about, do I have all the right rules in place around medical authorization? It's about caring for the patient.
What about patient engagement? Feels like the holy grail as I sit here and process and think about what you're talking about, even based upon some of the experience of the organizations that we kind of debrief with that were part of the Medicare carve-in demonstration. That patient engagement is so difficult. If you get a list of here's the name, the number, and then that's the handoff. Do you feel like, has anyone solved that, or is that like this whole new frontier that we're going to work on together if there is a carve-in world? So what are your thoughts on that? And maybe patient engagement. I've heard it framed as patient engagement. You may have a better term.
I mean, you're talking about like, when am I going to get a referral?
Yeah, and what that looks like, and how do you actually get them to uptake the palliative care and the hospice services? That was not done well in the demo. I don't know if you picked up on some of that, but it was not done well in at least one payer for sure. That was one of the biggest complaints.
Yes. Again, I think this has a lot to do with no hospice network, and I'm still paying daily rate on hospice, right? But if you asked any of the MA plans that we work with, do you believe earlier palliative care is better? They would say yes, but we can't pay that much for it, right? And the reason they say that is because the current financial economics are just, I'm going to pay for a certain number of months, and then I'm going to accrue savings when the patient goes to hospice. Like, there isn't sort of a whole value equation for them. We operated also in the high needs ACO REACH programs, right? And in that, you had a true PMPM for the patient for every month of service. It wasn't paid PMPM and then the patient goes to hospice and now you get a hospice daily rate. It's still a PMPM. In all of those cases, it was better to do palliative care earlier.
Mm-hmm.
Every single one, right? And so I think it would become pretty apparent to the payers quickly, I got to do palliative care. I got to figure out how to make these good handoffs. They have case management team. You know, you and I were talking earlier. We know the same group at Aetna. Like, they have case management teams who focus on chronically ill patients. There's some overlap with seriously ill patients. That's a nice mechanism to get referrals. They train PCPs all the time on different, referral pathways. They've figured out, how do I educate members about my meal benefit and my transportation benefit? I think IBX is the only plan, and we work with them, who has an actual defined palliative care benefit. But it is something that an MA plan can put in their C-SNP benefit and market it to patients. So I think there's a lot of venues for them to do a better handoff, but they're just not, I don't think they're going to care about it until they have the full spend of where this impacts the dollars. And then it's like a no-brainer.
Gotcha. Well, here's the last couple of questions as we come into a close. These will be fun for you. What are some of the biggest challenges you face when building a network of participating preferred providers?
Yeah, these are probably very similar to you. Challenges are that it's in flux every day, right? And so you identify great providers and they're doing really well, and then something happens and they're not doing that well. You're constantly trying to build new capacity. Folks are, going in and out of business. This is a tough business, right, to sustain. And so I think the hardest part is just, this is not the set it and forget it. This is you. Yeah. You wake up each day and keep doing what you were doing the previous day, trying to make some improvements.
It's job security, right?
Yeah.
There's no end of work to be done.
Yes, 100%.
So maybe a profile of your best partner, tech platform, network, association, health system. I don't know if you got kind of like your profile.
Yeah. We've got a number of great providers. I would say, similar attributes. They all have a multidisciplinary team. They rely heavily on social workers and community health aides, particularly to do some care coordination in between visits that might get done by an NP or an RN. Tech platforms, they actually all operate on different tech platforms. We have yet to see a good palliative care tech platform. So if
we're working on that one.
Yeah, if someone hears this and they want to build a new business, there's a hole for that. And then it's groups, I think, who have figured out palliative can be more than a loss leader for hospice, that sort of have the mindset that works really well in these programs, right? Where they say, great, like, I'm happy to get introduced and see this patient 8 months, 10 months before hospice, because that's going to pay dividends, versus some of the palliative groups affiliated with hospice go like, I thought palliative care was, one consult telling the person about hospice.
Yeah. Yeah, we just did a great podcast with the Jared Powell guys. And Eric Madera
Yeah.
said that someone had called sending him a squeeze ball, a palliative care program. I'm going, oh my gosh. So you kind of alluded to this in the Measures That Matter podcast, but I don't remember how you answered it. How often are you having to review the performance metrics to hold your partners accountable to? Like, how frequently are you guys having to look at that?
So we look at them every day, but we evaluate the providers every week. And every week, volume allocation may change based on how they did in the last week and their last month's performance.
That's incredible. That's really incredible.
Short cycles. I'm sure you see the same.
Yep. Yeah. And then just kind of maybe the last question. Most of what I read is people don't think the carve-in is going to happen anytime soon. What's Robin's opinion? Do you think that is there a window of opportunity coming back where maybe it may actually be feasible?
I think it may be feasible faster than that, particularly because what we have heard from some of this investigation that's happening on the CMS hospice fraud front today is maybe we will be able to claw back some of the money we lost, but this system will just keep losing us money.
Mm.
And we're talking about large sums of money. So it's sort of sad on one hand that the financial loss is maybe the largest motivating factor here, but I think it is motivating CMS, CMMI leaders to say, hey, if we don't fix this, like, we're just going to keep chasing the dollars.
Wow. Well, final thoughts. Robin, give you the final word.
Wow. Well, I know you started off, maybe still are, anti-carve-in, but I do really believe and would love, for the hospice providers out there to lean in to this. I think it can, and your network and your listeners, they're the high quality ones, right? So for these organizations, you're doing great work. I think you can make more money, not less, in a carve-in. And we can help more patients have a great experience.
Well said. Did you fully convince me? I am a hell of a lot more educated now than I do. And I do know where the issues have been. And I've got some ideas now just listening to you of maybe how we ameliorate some of those concerns that have been concerns and have not made the VBID demo kind of work out so well. Again, I probably should want it to happen because originally that's what birthed TCM. But to be honest with you, like what we've now created, that wasn't on the blueprint. It was just like, holy crap, if you get this carve-in, what are we going to do? They're not going to come in contract with all these individual hospices. And we just start solving problems. And now looking through the rearview mirror is like, wow, we've kind of created something pretty cool if that does come to fruition. But I would not be a person of integrity if I wouldn't ask those kind of questions, because at the end of the day, we want people to get great care. And unfortunately, every system's perfectly designed to produce the results it produces. Generally, health insurance companies are first and foremost about saving dollars, healthcare dollars. And so it comes from that scarcity mentality, and you apply that to end-of-life care, and it would seem like a whole bunch of bad potential unintended consequences. But you were very articulate, so I really appreciate you taking the time, and also you had the heads up. I'm like, I told you, hey, I'm kind of skeptical about this, but I'd love to bring you on the podcast and talk about it. So thank you, and thank you for the work that you and your team are doing.
I appreciate it. Thank you, Chris.
Well, and to our listeners, we want to thank you. At the end of each episode, we always share a quote, a visual. The idea is to create a brain bookmark, a thought prodder about our podcast subject to further your learning and growth and thereby your leadership. Going for like a brain tattoo, we want it to stick. Please subscribe to our channel. We don't want you to miss an episode. This is one definitely want to pay forward, maybe even to your board of directors, as well as your leadership team and even some staff. It's easy for us to rail against the world and be frustrated by things. Let's be the change that we wish to see in the world. So thanks for listening to today's podcast. And here's our brain bookmark to close today's show.
Every system is perfectly designed to get the results it gets. By W. Edwards Deming. Thank you, USI, for sponsoring this podcast.